So we'll talk about approach to focal lesions in a non-cirrhotic liver, right? So whenever you have a liver, you have to first see whether it's cirrhotic or non-cirrhotic. Your entire differentials, entire approach changes on whether it is a cirrhotic liver or non-cirrhotic liver. Okay, so whenever you give history, for example, you have to tell us it's hepatitis positive, negative. That is a very important part of the history. Okay, so what we'll discuss is imaging technique. Then we'll talk of certain common liver lesions. So I think today we'll just do probably hemangioma, FNH, maybe adenoma. Okay, and then we'll talk about approach. So probably tomorrow we'll discuss approach. Okay, so what is the triple phase CT protocol? Right, so we all see this triple phase protocol, but how many phases can you actually take in liver? Anyone? What are the different phases you can take in the liver? Arterial, very good. Portal, okay. Venous, delayed, and also non-contrast, right? So technically you can take up to 5 phases, right? And this arterial, portal, and venous. Now this portal term is a term used only in India. When I went to the US, no one understood what is. I mean, for them, portal venous is one phase. There's no portal phase and venous phase is separate. If you look at all articles, all textbooks, they don't talk of portal phase. They talk of portal venous phase, right? So. So plain or the non-contrast phase, we don't always need it in liver. Sometimes you may need it. Okay. Early arterial is the word. Okay. This is at 18 to 20 seconds. This is a angiographic sort of phase. So this is when the contrast is in the vessels. So when do you really need an early arterial phase? When you need to look at vessels, not when you need to characterize a lesion. Okay. Arterial enhancement you won't see so early. Okay. So this is for hepatic arterial anatomy. So this you may need to take if they want to do a angio or if they want to operate and they want to see the anatomy. Okay, but usually you can also see the arteries even in the late arterial phase, so it's not always needed. Okay, so the late arterial phase is what we call the portal venous phase. So in literature, this is the late arterial phase at 30 to 35 seconds. The portal venous phase is one phase, right? So portal phase and venous phase ऐसा कोई अलग से नहीं है. It's one phase and it's at 60 to 70 seconds. And the delayed phase at 3 to 5 minutes. This is for CT. Okay. So when they say triple phase, actually what we need is these three: late arterial, portal venous, and delayed. These are the 3 standard triple phase CT phases. Okay, you may take a non-contrast phase, usually in cirrhotic livers, not usually required in otherwise, and not always even in cirrhotic livers. And the early arterial is very rarely you need it. So we need these 3. Okay, we need the delayed for a liver lesion. If you don't take the delayed, it's not a triple phase protocol. Okay. Yeah, so this is the difference between, so what is early arterial and late arterial? So early arterial is angiographic phase. Okay, so only arteries are pacified. In late arterial, little bit of the portal vein is also pacified. Okay, so this is how you will visually differentiate, right? So when you take the scan, it's different. But when I'm reporting the scan, how do I know this is early or late arterial? If I see some contrast in the portal veins, then I know it's a late arterial phase and not an early arterial phase. This is the ideal phase to take because arterial hypervascularity, arterial hyperenhancement, we can catch here. On the early arterial, we have missed it, right? So here's a lesion which you can barely pick up here, right? But on the late arterial phase, it's very clearly hypervascular because this is too early, right? This is just way too early to catch. Okay, so we need the late arterial phase. Okay, so always remember that. Okay, for MR, what do? We take so these are standard sequences, right? You take the T2 weighted images, axial coronal. You take an in and out of phase images. This is for intralesional fat. You take a T2 fat set image and usually cyst hemangiomas will stand out here. So cyst hemangiomas extremely T2 but it will stand out here. You take a diffusion and diffusion of course will you will be able to evaluate malignant lesions, but also T2 shine through is useful. So cyst for example will show T2 shine through and hemangioma will not show as much. So you will be able to sort of differentiate them. You need the dynamics, right? So take the dynamics to look at the enhancement pattern, and if it's a T1 bright lesion, you need to look at subtraction images. Okay, and then there's something called hepatobiliary phase if you have given hepatocyte specific contrast. So what are the hepatocyte specific contrasts? Yeah, so gadoxetic acid and multi-ans, these are the two, right? So gadoxetic acid or eovist and multi-ans. So gadoxetic acid is not present in India. It's not available in India. So for us it's multi-ans. So we'll discuss what are the differences in the two, and sometimes you may need to do an MRCP for liver. Okay, so multi-ans is the one we have available. So it has only 5% hepatocyte clearance, right? So 95% excreted by the kidneys. 5% of the contrast is taken up by the hepatocytes, and after they take it up, they excrete it in the bile ducts. Okay, so because it's very low hepatocyte clearance, the HB phase takes time to come. So you will get it only at 1 to 3 hours. So in order to really do a scan and get the HB phase for multi-hands, you have to remove the patient, take another patient, finish that scan, then take this patient again, and then rescan, do a T1 weighted image, and then see if you see the bile ducts looking bright or the gallbladder looking bright on the T1 weighted images, that means there is contrast within them. Then you know you have reached the hepatobiliary phase. Okay. So if you don't see it, then that means it's still not there. Then you need to take another patient. Then again after that you take this patient back. So hepatobiliary phase you will have to basically check based on whether you see contrast in the bile ducts. Alright. So the advantage of this though is because it is excreted mainly by kidneys, you get a very good dynamic phase images. So most of you have not seen NeoVist, right? None of you have seen NeoVist. So NeoVist, the dynamic phases are horrible because it just the liver takes up the uptake very quickly. So you cannot differentiate the enhancement in the vessels versus the enhancement in the rest of the liver. It just washes away too fast. So it's not very good for dynamic. So this is actually a very good thing because you can do dynamics and then after that you can take the hepatobiliary phase, but the workflow is a little more difficult. On the other hand, in NeoVist, what is simpler is the workflow. So in NeoVist, there's 50% hepatocyte clearance, right? So half the contrast is taken up by the liver. So hepatobiliary phase comes very quickly, right? So in 20 minutes you'll get a hepatobiliary phase, which is fantastic. So within one time point, you can scan the patient completely. So if you want to do an NeoVist scan, if you actually have NeoVist, you will start with a few T2 weighted sequences, then run the dynamics. After that, you will do your diffusion and stuff like that to wait for the 20-minute, and then you'll do the 20-minute. So within this entire 20 minutes, you can actually finish up the scan. But it's not easy to get good dynamic contrast enhanced images. Okay, so that's a drawback of yours. Okay, also hepatobiliary phase depends on the functioning of the liver, right? So if it's a very cirrhotic liver, it's not functioning very well, the LFTs are very abnormal, then you might not get a good hepatobiliary phase simply because the liver is not functioning, so it will not have hepatocyte uptake, right? So if it's like an end stage liver disease, then your hepatobiliary phase may not help that much because it's the contrast is not getting taken up by the liver at all. Okay, so that also becomes important. When do you really do an hepatobiliary phase? So when you are scanning a patient, when would you want to do? If you are suspecting FNH versus some other lesion. So one of the common indications, right, is that is it an FNH if it takes up contrast on the hepatobiliary phase and it's an FNH. So whenever you have a doubt is it an FNH or not, then we can do this. If you have no doubt, you don't need to do this, right? So it's very clear it's an FNH, then you don't need to do this. But often we will do a CT, we think something we're not sure is it FNH or not, we will recommend an MRI with hepatobiliary phase, right? Hepatobiliary phase will detect around 10% extra HCCs compared to your regular contrast and in cirrhotic livers on an average, that's the literature. So we can detect early or small HCCs with hepatobiliary phase because on the delayed, so you might not, some of you might have seen the hepatobiliary phase, right? The liver is super bright and anything which is not picking up contrast is super dark. So the contrast is excellent. It's very easy to pick up small lesions. You can detect subtle liver metastasis again. So some institutes will do a hepatobiliary phase study to do out liver mets and certain cancers, okay, and small liver mets which are missed on a regular extracellular contrast will be caught on the hepatobiliary phase. Okay. Yeah, ruling out metastasis. So what I mean by this is, sometimes you don't know what the lesion is. So it's happened a couple of times in Tata. We are not sure what the lesion is, but we give contrast and the lesion is not dark on the hepatobiliary phase. That means it is not metastasis, right? If the lesion is not dark on the hepatobiliary phase, means it's picking up contrast. So it may be whatever, it may be focal fat, it may be some weird thing, but it's not metastasis. So in Tata, it often helps in ruling out metastasis. At least 2 or 3 cases we have seen, but it has helped that way. And neuroendocrine tumors, often people will use hepatobiliary phase because depending on your arterial portal venous, the metastasis will look very different. On each phase, they enhance very differently. So on follow-up, it becomes very difficult to compare them because on one scan, maybe you did a 25 or 30-second late arterial. Another scan is a 35-second and they look very different. So you're not sure whether they actually increased or it's just because of the phase of the contrast that look different. So many people will do it in neuroendocrine especially. And yeah, last thing to evaluate for bile leaks or bilomas, right? So when you're not sure bile leak is there or not, you give the contrast and you see contrast in a collection, then you know there's bile leak. Okay, so that's about the technique of scanning. So yeah, so there are different hepatic lesions like cyst, FNH, hemangioma, adenoma, cholangio, HCC, mets, and infections, and then some others also, right? So when we see a liver lesion, so I'm not going to discuss all of them today. But when we see a liver lesion, first thing you have to be sure it's a real lesion, right? So we'll often see focal fat in Tata, right? And there are every month or two I'll see one resident, usually an early sort of resident, second year or late first year, calling it a true lesion, right? So that's something you have to be very sure of. You have to rule out a pseudo lesion, right? So generally, if you see anything which is more geographic, what do you mean by geographic? It is not a very well-defined thing. It's not a very well circumscribed entity. It looks very ill-defined, slightly hypodense, and it's usually along the areas of the fatty liver changes, right? So it's usually along not fatty liver changes, focal fat changes, right? So usually along the falciform ligament, gallbladder. So this is almost always going to be focal fatty change, right? It's almost never going to be METs. If you see a very well-defined thing, then you might, be a little more circumspect and say this could be focal fat or MET. But when you see something like this, is almost all. This is definitely focal fat, right? And here you can actually even see a vessel coursing through it, right? So that's another way to identify it, right? Okay. And sometimes you can look at a non-contrast. Non-contrast is nice and fatty, right? And this is focal fat. This is not MET. Okay. Sometimes you will see something like this. This is generally you will see it in a cirrhotic liver. Okay. So you see T2 bright lesion. You see an arterial phase is hypervascular, and on the venous it sort of retains its contrast. It is following the blood pool, and the diffusion is pretty dark, right? So this is a shunt, right? So this is a shunt. And often you will, not often, but you will definitely see some shunts in cirrhotic livers. So in cirrhotic livers you have to think of shunts. In a post biopsy liver you have to think of shunt, not otherwise. Generally, intrinsic shunts don't generally happen in adults, right? So, but this is another thing you have to take care of when you look at a lesion. So this was the Doppler of that lesion, and this was a shunt. Okay. Alright, so simple cyst is straightforward, right? But often I still see reports which is cystic lesion instead of calling it simple cyst. There's a big difference in cystic lesion and simple cyst. Cystic lesion can be malignancy also. Simple cyst is always benign. So when you see a simple cyst, you just call it a simple cyst. I wouldn't even describe it. I wouldn't put in my report here there's a 3 centimeter well-defined homogeneous hypoattenuating lesion. I just say there's a simple cyst and leave it there, right? So it's a non-brainer. No one cares about it. So just describe it quickly and move ahead. Okay, so it's sharply marginated always, homogeneous, low attenuation. Rarely there will be bleed or infection. It's almost never, right? So it's almost always sharply marginated, homogeneous, low attenuation. Sometimes there can be pseudo enhancement. So it might be like 20 or 10 on the non-contrast and more than 10 HU in the contrast. So pseudo enhancement can be there. So don't worry too much if it's just like 10-20 HU enhancement. That is fine. That can happen in simple cyst. Okay, the problem is when it's a 4 millimeter TSTC, too small to characterize lesion, and patient has gastric cancer or colorectal, then you just say it's a too small to characterize lesion, right? Then you say it's a hypodensity 4 millimeter, too small to characterize, indeterminate, and leave it there. Okay, usually almost all of them are simple cysts, but you can't be 100% sure, so we use this term, too small to characterize or indeterminate 4 millimeter hypodensity. But whenever it's a clear-cut cyst, then you just call it a cyst and leave it there. Okay. You don't have to do an ultrasound in most cases, right? Sometimes if the HU is 30, 35, you're not very sure, then you can say do an ultrasound to characterize it. But often I see a lot of reports where we recommend ultrasound without any reason. Okay. So if you are it's very clearly simple cyst, just call it simple cyst and go ahead. So hemangioma is something everyone needs to identify and be very confident about, right? So it's the most common hepatic lesion per se. Okay, I mean ignoring cyst, this is the most common hepatic lesion. Okay, and everyone knows the classic description. It's homogeneous, it's a hyperechoic mass, well-defined margins, right? It's a well-defined lesion, and it's posterior acoustic enhancement often seen, right? CT, there are 3 different enhancement patterns, okay? And we have to remember, especially the classic enhancement pattern, pit pat, okay? So this is the classic enhancement pattern, right? What is it? Peripheral, discontinuous, nodular enhancement with centripetal filling in. Okay, so these are all these terms are important and you have to remember them. So it will start as peripheral enhancement, okay, discontinuous, never rim enhancement. Okay, rim enhancement is something you have to worry about. Okay, that's in infection or it's malignancy, right? So it should be discontinuous, nodular, right? Nodular or globular enhancement we call it. Okay, so it's not like a curvilinear enhancement, it's a nodular or globular enhancement. And then on the delayed or portal venous phases, there's continuous filling in happening. Okay, but it may not fill completely by the 3-minute scan. If you take a 10-minute, you will see even more filling in. That may happen. But as long as you are seeing filling in, it's a classic hemangioma. Okay. Generally, this will the attenuation of the enhancement will match that of the aorta. So on late arterial it will look as bright as the aorta. On venous it will become slightly less bright, again similar to aorta, delayed again less bright, but it will usually match the aorta. It's a vascular lesion, right? Okay, so I don't know if it's projecting very well. Not really, is it? Okay, so but this was a hemangioma, right? So you can see continuous centimeter filling in, and it's discontinuous, right? Let's see if I don't have a better image. Sorry. But this is like a classic hemangioma. Okay. Then the second type is a flash filling hemangioma. So here it just fills completely. Okay. On the late arterial phase, it's completely filling. And again, portal venous or delayed, it's sort of iso to the aorta, right? So that helps you. It remains iso to the aorta. Here sometimes the differential is an FNH, which we'll discuss later, but it doesn't matter, both are benign lesions. So as long as it's a nice, completely filling enhancing lesion, you don't have to worry too much about it. Okay, I can call it flash filling hemangioma / FNH, and both are benign, no one really worries about them. Okay, yeah, so this is your flash filling hemangioma, right? So it's enhancing nodular enhancement on the late arterial phase, remains iso to the aorta on the portal venous phase, right? And you can see a small thad, right? So that's because it's of the vascularity of the lesion, right? So small thad may be present, but that's not necessary, right? Often they are even smaller than this. This is a very obvious big one, but often they are like 4-5 millimeter enhancing nodules, and then they won't see a thad. Okay. But yeah, when you see these lesions in a non-cirrhotic liver, don't worry. You can call them benign. You can say they are either flash filling hemangiomas or FNH, and that's it. They're benign. Yeah. So here is, for example, so this is a patient of gastric cancer, right? So this gastric cancer, and you can see this hypoattenuating lesion with, maybe a slight rim enhancement, and you can also see this lesion, right? And this is very different from this, right? We can clearly see this is a nice hypoattenuating, very suspicious looking lesion, while this is a nodular enhancing lesion, right? So this is clearly met. This doesn't look like met, right? So in most cancers, mets are hypoattenuating, right? Very few cancers are hypervascular mets. And here when one met is hypo, then this is clearly not met, right? So we will say that this is not a met. This is a flash hemangioma FNH, while this is suspicious. This is a met. Okay. And you can see on the follow-up, post-chemo this has decreased while this remains stable, right? Because it's benign. Okay. So this you have to be confident about. Even when you see mets elsewhere, you can call this as a benign thing, right? And this is the third sort of pattern. It's less common, but we often see it, right? And this is that you just see an eccentric sort of dot. So these are very slowly filling in hemangiomas. So just a small eccentric dot is there, which is again matching the blood pool. And you may or may not see filling in on the 3-minute phase, right? So the filling in might be very slow. So you might not be able to catch it at the 3 to 5 minute delay. Okay. So for example, here is something, right? So again, a patient of cancer with mets elsewhere, but you can see this, right? Eccentric dot. It's very unusual for met to present like this, So this was a hemangioma, and you can again see. So on the next scan, again you see an eccentric dot, right? And it's stable. Okay, so when you see that, so this is another one, right? Eccentric dot. When we see this, we should think of hemangioma. So if you're not very confident on CT, you can always ask such patients to undergo an ultrasound or MRI. But generally you see this, and I would be very confident calling this as a hemangioma. Okay. Alright. So these are 3 enhancement patterns. Okay. Right. So this is your peripheral discontinuous nodular. This is a better image, right? So peripheral discontinuous. You can see it's discontinuous nodular enhancement, and then centripetal to fill in. Okay. Yeah. The another thing is in Tata you will also see multiple scans of the same patient, right? So sometimes in one scan it's not very clear. Is it benign, malignant, is it hemangioma or not? But hemangioma, the main thing is a vascular lesion, right? So in every scan there will be slight difference in how it appears because your flow dynamics of the blood and the timing of the contrast injection always is slightly different in every scan you do, right? So the same lesion, if it keeps appearing different on multiple scans but remains stable in size, then that's a hemangioma. So here is a lesion. So here, see, this is not very nodular enhancement, right? This is a curvilinear sort of enhancement here, and here you can see some nodular enhancement, right? This is discontinuous. And then you're like, well, is this hemangioma, is it not, right? So you can see some peripheral discontinuous nodular enhancement here, but then here it's more curvilinear sort of enhancement. So you're not sure, is it met, is it benign? You go to the next scan, now you see more globular, pools of contrast. You go to the next scan, again you see more globular pools. So every scan will look different, right? When that happens, then this is a hemangioma. Okay, this is a definite hemangioma. Another next scan. So depending on the phase and depending on how the patient's blood flow is, right? So it will keep varying. The appearance will keep varying. but we know this is a hemangioma when you see this, right? So then you can confidently call it a hemangioma. Okay. So the first time point you might call it an indeterminate lesion, right? But then the next time point you should call it a benign lesion. You should call it a hemangioma. Don't keep calling it indeterminate at every time point. Okay. Okay. So on MRI, so vascular lesions on in principle will be T2 bright on MRI, right? Vessels, blood, anything which has a lot of blood, it will be T2 bright on MRI. So vascular malformations are T2 bright on MRI, right? Similarly, hemangiomas are T2 bright on MRI. Okay, so they'll be super bright on MRI. So CSF intensity. So just on T2 actually you won't be able to be even say that this is cyst or hemangioma. Both are sort of equally bright. Okay, yeah. And then what happens? They remain bright on diffusion in the B0 value, but then its value keeps dropping, right? So on the higher B values, so the T2 shine through effect goes down. In the cyst, it remains, right? So if this was a cyst, even on the B1000, it would remain equally bright. Okay. If this is a hemangioma, in the B500, B1000, you can start seeing drop in the brightness. Okay. So T2 shine through effect sort of goes down on the high B value images in a hemangioma. It sort of remains there in a cyst. It's not important, right? No one is going to use this to differentiate, but you can. So there are institutes where you will do multiple B value images for this purpose. But generally, if you're anyway giving contrast, which you almost always do in Tata, it's fine. You don't need all this, right? It's very straightforward diagnosis. Okay, but this is good to know in theory, right? And they'll always be bright on ADC, right? So they will not restrict. Okay. Okay, right. So incidental hemangiomas, you should be able to usually diagnose them on CT. Do not recommend an ultrasound unless you really have a doubt, right? So now you know the three patterns. If you see that peripheral discontinuous nodal enhancement, even if you don't have a delayed, suppose this is not a liver scan, it was a routine scan, you still call it a hemangioma. You don't need the delayed every time to really call it a hemangioma. If the pattern is classic, you call it a hemangioma. Okay. So recommend ultrasound only if there's a doubt. Okay. Right, so again here I don't think it will project very well, but you can again, this is an indeterminate sort of lesion. What you see this dot here, and again you think of a hemangioma, right? So often these single time point become a little more difficult. So based on your confidence, you may call it a hemangioma or you may ask for an ultrasound. Okay. Right, so here the provisional said it's a indeterminate lesion and it's fine. It's fine. But then I was very confident. I don't think it's projecting very well. But there's this eccentric nodule here. Okay. So then I called it a subcapsular lesion with peripheral nodular discontinuous enhancement consistent with hemangioma. So I call it hemangioma and remove the ultrasound. But then this is a comfort level. So slowly you start becoming more comfortable. And whenever you have a doubt, you can do ultrasound. No doubt about that. Okay. Now, these are the classic hemangiomas, but you might see atypical hemangiomas. Okay, the most common one is this giant hemangioma. They call it more than 10 centimeter. It may cause pain. It may cause Kazabag-Merit. You know what is Kazabag-Merit? You know, consumptive coagulopathy or thrombocytopenia happens, all of that, right? So that can happen. Pain is there because of capsular stretch. So it's too big. It will stretch the capsule and that will cause some pain. Okay, here of course again CTMR is useful, but it will be more heterogeneous, right? Because there will be thrombosis, there will be fibrosis. It's not a very homogeneous lesion anymore. Okay, but usually the enhancement pattern, in the sense the areas which are enhancing will follow the hemangioma rule. So they will follow the blood pool. There are a lot of areas which are not enhancing, but those which are enhancing will follow the blood pool. Okay, so for example, you can see peripheral discontinuous nodal enhancement here, right? And on delayed, we don't have the delayed, but there might be some filling in, but most of it will remain hypo because much of it is thrombosed or fibrosed. But when you see this, you think of a hemangioma. Okay, and MRI often helps here because again it's extremely T2 bright. Again, these areas will be extremely T2 bright, so that way an MRI will help. Okay. There are other things also, like sclerosed hemangioma. It's very difficult. Okay, so sclerosed hemangioma is sort of, it's fibrosed completely or quite a lot. That is difficult to differentiate from cholangio if that classic peripheral nodal enhancement not present, because even cholangio can look like that. Sclerosed hemangioma can cause capsular retraction because of the sclerosis, and a cholangio can do that. So sometimes it's not, you cannot be very sure about calling it a hemangioma or sclerosed hemangioma. So here it's not that difficult. You can see this dark scar in the center, T2 bright lesion, and again on the delayed, it's enhancing homogeneously, matching the blood pool with a scar in the center. So this you are more sure, but sometimes there will be capsular retraction. It will have sort of more rim sort of enhancement if there's too much fibrosis, and then filling in. And then you're not sure. Then you'll have to do a biopsy or some other investigation. Okay. Hemangiomas can be calcific, can be multiple. There are other patterns also. Alright, so there's an article in abdominal radiology. I just shared it on the group. Everyone should read. So it shows all the different patterns. So you can have sometimes centripetal enhancement instead of centrifugal enhancement and centripetal enhancement. You have one case of that in Tata. As I said, you can have capsular retraction. Different enhancement patterns are there. So I'll just share that article so that you can read that. Okay. Alright. So then we come to FNH. So everyone understood hemangioma. This is the most common lesion. You have to know everything about hemangioma. Okay. Okay, so FNH is a very common lesion. Okay, so it's the second most common lesion generally in ladies. Okay, it is made of normal hepatocytes. That's the main thing to remember. FNH is made of normal hepatocytes. It's an aberrant response by the hepatocytes to a dystrophic vessel. Okay, so the dystrophic vessel is the center of the lesion, and then there's aberrant proliferative response of the hepatocytes to this dystrophic vessel. Okay, and that is what forms this FNH. Okay, so it may be associated with other vascular abnormalities. It often just as a standout individual lesion. But because it has normal hepatocytes, it will mimic normal liver. What does that mean? It will be iso to the liver on ultrasound, on CT, on MRI in most cases, right? Because it's normal hepatocyte. Why will they look different from the rest of the liver? Okay, sometimes if it's big, you may see some mass effect around it, but often it will just look like all of this will look just like normal liver. Okay, it will be iso. So only on contrast will be able to catch it. Okay, and because it has basically this aberrant vessel, it will enhance a lot on contrast, right? Okay, so in ultrasound generally it's iso. We'll often miss it. If it's very big, we can catch it. So here is slightly hyper, right? So we can sort of catch it here. Sometimes it shows mass effect, so you can catch it that way. Okay, if you put a Doppler, you may sometimes see central pickup of the color, right? And that's because the central vessel is there, right? So there are central feeding arteries, so there's central pickup of the Doppler. Okay. You may see a spoke wheel pattern, meaning center say you can see vessels going to the periphery, but that's not very easy. It's very uncommon to see it. Okay. Because it's a dystrophic vessel, if you actually put a Doppler, dystrophic vessels means the resistance is low, right? So it will be low RI. Okay. And the enhancement is centrifugal, right? So the vessel in the center enhance first. If you do contrast and ultrasound, the vessel in the center enhance first, and then the contrast will diffuse to the periphery. So centrifugal enhancement on the ultrasound, and the contrast will be retained on the ultrasound, on contrast enhanced ultrasound. Okay, so we generally don't do this. So, but it's just good to know. But you can make, this sounds sensible, right? The central artery enhance first, and then it will diffuse to the periphery. So centrifugal enhancement you can remember. Okay, retained contrast and delayed, I don't know, I don't remember the exact pathology for this, but you have to remember that. Okay, so this is a late article. You can see now it's filled up, right? So the early article, there's central enhancement, spoke wheel pattern, and then filling up. Okay. Okay, on the CT or MRI, as I said, on the non-contrast images, it will be pretty much homogeneous, very difficult to appreciate. Okay. But on the arterial, because it has this aberrant vessel, it will be extremely enhancing, right? So generally this is the classic thing, homogeneous intense arterial enhancement. Okay, so you see this and this is an FNH, and it will become pretty much iso, sometimes slightly hyper on the venous and delayed. So this is where it differs from your hemangioma, right? Hemangioma, if it is a flash filling one, it will remain as wide as the aorta. This drops very fast. Okay, usually it will iso, sometimes it will remain slightly hyper. Okay, so see on delayed is now iso, right? So you can't really even realize that there's a lesion there. Okay, so that's an FNH. Okay, so if you remember the pathology, you will pretty much predict what is happening, what is going to happen on the imaging. Okay, you may see a central scar. If you see a central scar, again that's very classic thing. So the rest of the lesion will enhance a lot on the arterial. Central scar will not enhance on the arterial, right? So that's a classic description. So central scar is the vessel, right? So it's a vascular scar. So the scar will have the vessel in it. So again, anything which is vascular is bright on T2, right? So if you do an MRI, the central scar will be bright on T2. Okay, so here's the lesion, and here's that. So this is the lesion. So lesion, as I said, is generally iso. Here again, slightly hyper. This is the central scar, T2 bright. And the central scar will show delayed enhancement. So rest of the lesion will enhance on the arterial. The central scar may show delayed enhancement. Okay. So this is arterial enhancement, right? Generally you see homogeneous enhancement, but this pattern of enhancement also displays called popcorn enhancement. Okay. It looks like a popcorn, right? So this sort of enhancement can also be seen in FNH, right? So the homogeneous intense enhancement, or this popcorn-like pattern of enhancement, both are classic descriptions of FNH. And on a delayed, you will see the central scar enhancing. Okay, so this is a classic FNH. Once you see. So when you see this, do you need a hepatobiliary phase? You don't need it. But not all FNH are classic. So when you're not sure, you can do a hepatobiliary phase. And again, because it's functional hepatocytes, they will show uptake. Okay. So, so this example I've taken from a journal, right? So intense arterial homogeneous enhancement apart from the small central scar on the arterial phase. On the hepatobiliary phase, this is picking up contrast. So this is a nice photo of a hepatobiliary phase, right? So all and the entire liver looks super bright, right? So you can clearly see the difference between a vessel and the liver, right? The contrast is just excellent. So which is why any small met, any small lesion, very easy to catch on the hepatobiliary phase. Now this is not dark, which means it has functional hepatocytes. So that's a classic FNH, right? Okay, so MRI per se is excellent, 70 to 80% sensitivity, 90% specificity to diagnose FNH. If you get hepatocyte contrast, then the sensitivity increases further. Specificity is slightly increased, but still not super different, right? But there are atypical FNH. So 20% FNH are atypical. They will not follow the book. So they may show fat within. Then it's very difficult to say this is a adenoma or FNH. Generally, when you see fat, you think of an adenoma, right? In a young woman, right? So remember, FNH is women, right? 90% in women. Okay, they may be T2 bright instead of sort of ISO or just slightly, but they may be nicely bright. They may have a pseudo capsule, so they have a rim enhancement on the delayed. They may show washout also, or they may show delayed enhancement. So any sort of variable features can happen. So this is, for example, arterial phase. So it's not intense enhancement here, right? It's not intense enhancement. And there's washout on the delayed, right? This was a non-cirrhotic liver. We didn't know what this is. So we had to biopsy. When we biopsy, this was an FNH. Okay, so when I see this on CT, would I recommend a biopsy versus a hepatobiliary MRI? I would recommend a biopsy because there's nothing on this to make me think of FNH. And the washout makes me a little worried. So adenoma, of course, it can still be an adenoma. But I think this was not that classic age group, right? So we biopsied this one. This was an FNH. Yeah, so this is what EASL guidelines say. If it's less than 3 centimeter, think of doing a contrast ultrasound, which we don't do, right? Okay, if it's greater than 3 centimeter, biopsy. So generally, most of our lesions will be large only, right? So generally, we will end up biopsying if it's an atypical thing. Okay, rather be sure about it. Alright, so adenoma is a third sort of common lesion that you will see, like a non-cirrhotic liver, non-malignant lesion that you will see. Okay, again, female preponderance, right? So mostly in females. 9:1, so 90% female, just like a FNH. Okay, but if a male has an adenoma, that's a high risk thing. So you need to resect it, you need to treat it. Okay, there are certain predisposing factors which we are aware of, right? So oral contraceptives, androgen exposure, glycogen storage disorders. So you don't see that often, but that's a predisposing rate. And then this sort of diabetes. Okay, what are the two main complications we are worried about in adenoma? One is hemorrhage and one is malignancy. So there are two things you're really worried about. Okay, hemorrhage is much more common, malignancy less common, but it's not uncommon, right? 4 to 5% is a decent chance. Okay, I would be worried if someone says you have 4% chance of malignancy, right? So you have to be very careful of adenomas. You have to follow them very carefully. Okay. Now you can see any type of imaging pattern with adenoma. Some will enhance, some will not enhance, some will wash out, some will not wash out, some will have fat, some will not have fat. So it's a very differing imaging appearance, which is why it's very difficult to diagnose. But the main thing to remember is adenoma is not one entity, it's actually multiple different entities. So there are different subtypes of adenomas, and these different subtypes will have differing imaging features. Okay. So I say there is a good type of adenoma, the bad and the ugly type of adenoma. Okay. Have anyone seen this movie or heard of this movie? Good, bad and ugly. So this is a good type of adenoma, the HNF1 alpha mutated adenoma. If you don't remember this mutation on exam, no one is going to fail you. But if you remember, you might get a gold. So it's a sort of a nice to remember thing. Okay. So this is the second most common. It's not the most common type, but this is a good type. Okay. 30 to 35% have it. 90% will have history of oral contraceptive. Okay. So mainly women, of course, but usually this is associated with oral contraceptives. This is the one which will have fat in pathology. So steatosis is present. Associated steatosis can be familial, so often multiple, right? It will run in families, often multiple, and usually these are asymptomatic. So the good type, right? So good type should not present with symptoms, right? So this is a good type, really asymptomatic. You will catch it incidentally. Okay, so we see multiple adenomas with fat within them. You can actually in a report say, given the morphology, this is likely an HNF alpha mutated adenoma. Okay. So on imaging, what do you see? Again, you have to remember steatosis, right? So it usually eyes will be mildly bright, it won't be super bright, and there'll be no delayed enhancement. So why am I saying this? Because other types might have delayed enhancement. So there'll be variable enhancement, but it won't be delayed persistent enhancement, and there'll be fat. So there'll be T1 bright lesion with intralesional fat. So example, here's a lesion, T2 bright, multiple lesions, right? Multiple lesions, mildly T2 bright, and you can clearly see it's T1 bright, dropping signal on the outer face. So this is having intralesional fat. So this is multiple sort of fat-containing lesions in a young woman, and that's your hepatic adenoma. On the delayed, there's sort of hypoenhancing. Okay, so no delayed persistent enhancement. So that's your. So once I see this, I can, of course, I'll say this is adenomatosis, and I'll say most likely HNF1 mutated, alpha mutated adenomas. Okay. The second type, this is the bad type. It's called inflammatory adenoma, telangiectatic adenoma. Again, if you know the pathology, you can predict what will happen. So telangiectatic means again a lot of vessels, right? Telangiectasia is a lot of abnormal aberrant vessels, just like the FNH had aberrant vessels. Yeah. So this also will have abnormal aberrant vessels. And this is inflammatory type. So that's the other thing, meaning there is inflammation happening. Okay. So you will see inflammatory markers, sort of. If you do a biopsy, you will see leukocytes or whatever. Alright, so inflammation and telangiectasia are both components, right? So if you remember this much, you can again predict. So often, if you know the pathology, you can predict what the imaging will be. Okay, so these are the most common. Alright, inflammation, vascular abnormality, angiectasia, pileosis, sinusoidal, lots of various vascular abnormalities. So because it is vascular, what is the highest risk? Bleeding, naturally, right? A vascular lesion will have high risk of bleeding, but there's also some risk of malignancy. Okay. So what are the imaging features? If it's inflammatory, how do you think it will look on T2? Bright, right? Inflammation, right? Again, and if it's vascular, how it will look? Bright. So these are generally bright and generally brighter than the HNF1 alpha, but basically T2 bright lesions. Okay. And on enhancement, what will happen? If it's a vascular lesion, what will happen on the delayed? What happens to hemangioma on the delayed? Any vascular lesion, what happens on the delayed? Persistent enhancement, right? Delayed enhancement will be there. So classically they say marked T2 hyperintensity. Okay. I often seen that it's not that marked. I mean, it's bright, but it's not like super bright. But there will be delayed persistent enhancement. So these are two things. There's this sign called as the atoll sign. Okay, so the atoll sign. What is an atoll? Anyone knows what is an atoll? Group of islands. Yeah, very good. So group of islands. So the classic Maldives photo or Andaman photo, na, upar se lovely small islands. And usually, what do they see? Baju mein there's this blue rim. So I'll show you a photo actually. But you see this atoll sign, I'll tell you why you see it, okay? Now the problem is, this can also sometimes show uptake of hepatocyte contrast. So FNH is not the only thing. Sometimes an adenoma, this particular adenoma, can show uptake of hepatocyte contrast, okay? Okay, so this is your, T2 bright lesion, which showing persistent enhancement on a delay. So this is an adenoma. Okay, it's bright as I said, but not super bright, right? So, but this is your classic inflammatory adenoma. This was our patient. And this looks like very heterogeneous, dirty looking lesion, right? We did an MRI, again very heterogeneous. On the T1 you can see, what is this? T1 bright, which is remaining bright on the outer face. Bleed, right? So there's bleed. So this is a lesion which has bled. This one actually also had some intralesional fat. So you can see some T1 bright portions which are actually losing signal. So there's some intralesional fat also, right? But in a young woman, when you see something which has bled with some fat, you think of an adenoma, right? So we call it an adenoma. This turned out to be an inflammatory adenoma. Okay. Yeah, this is the atoll, right? So this is a classic photo, right, of Andaman and Maldives. So these are atolls, and you see this periphery which is sort of bright, right? So that's the atoll sign. In an inflammatory adenoma, the periphery will be bright because of compressed sinusoids, right? So again vessels, so bright. So that's the atoll sign. It's not very commonly seen. Okay, so it's a very uncommon sign, but people might ask you in the exams. So that's the atoll sign. Okay, have you understood this? Okay, then the third type is the ugly type, the beta-catenin mutated. So actually there are 7 types of adenomas. Okay, but these 3 are the ones you need to remember. Okay, so this is uncommon. It's maybe actually, so this is actually 2 types, right? It's exon 3 mutation, exon 7 mutation. Don't worry about all of that. Okay, just think of beta-catenin mutated adenoma. Problem is there's an increased risk of malignancy when with one of these beta catenin mutated adenomas. So this is the ugly type because that's the worst thing you worry about, right? Malignancy. And the problem is there's nothing on imaging that can differentiate or tell you that this is a beta catenin mutated adenoma. It can be T2 generally it is mildly hyperintense on T2, T1 dark. It may have a central scar, may not have a central scar. It may show enhancement on the arterial. It may show washout on the delayed. It may show persistent enhancement on the delayed. So anything can happen. So there's no way you can really differentiate. The only way to differentiate is by biopsy. And then on biopsy you look for whether there's beta catenin mutation present. So not much you can do, right? So here's a case. This is when I was in Seattle. So this is a patient with glycogen storage disorder. So we know, right? We just discussed that glycogen storage disorders have a increased risk of adenomas. So multiple adenomas were there. This is a man again. Increased risk of malignancy is a man, right? So you can see this adenoma nicely enhancing on the arterial and delayed persistent enhancement present, right? So this was an inflammatory adenoma. And then this adenoma enhancing and then washing out with the capsule. So this actually increased slightly from the previous. So these was in follow-up, right? So we asked for a biopsy. This was a beta catenin mutated adenoma which a focus of HCC within it. Okay. So then they resected this thing, or I think they resected or they RFA. I'm not sure what they did. But this was a beta catenin mutated adenoma. Okay. So if you see this, you think about it. But often they will look like this also. So really, it's very difficult to be sure. Okay. So follow-up becomes very important in adenomas, right? Now these are the other types. There's something called Sonnen-Hitchcock. There's an unclassified adenomas. There are various other types, and don't worry about them. Okay, so right. So these are three main types you have to remember, right? So the one which will be generally hyper is HNF alpha. This may be hyper because there may be bleed in it. Okay, this can look like anything. T2 may is supposed to be more bright than this because it has vessels and inflammation. Okay, fat. This will often have fat. This may sometimes have fat. Okay. They will usually enhance on the arterial. This will enhance quite a bit. Okay. On delayed, this will usually wash out in the sense there won't be delayed persistent enhancement. Become ISO more or less. Okay. This will show persistent enhancement. This can actually wash out. It can remain ISO. It can remain bright. Anything can happen. And then there is the atoll sign. So these are things which are there, right? Okay, so the main thing with adenoma is the complications, right? So what you need to know is when do you need to intervene. Okay, so one is if you so first complication, hemorrhage, right? So when is the chance of hemorrhage in a person higher? If the size of the adenoma is more than 5 centimeters, so you have to give the sizes is important, right? The largest adenoma, there are multiple, so the largest measure is this much. If it's more than 5 centimeters, they will treat it, they will resect it because the chance of hemorrhage is just too high. Okay, if it's an inflammatory adenoma, they will generally they will worry more because it can undergo hemorrhage, right? But again, so this is unless you biopsy, you will not know Sonnen-Hitchcock, so forget that. Exophatic adenoma people will worry about because it can bleed into the peritoneum and cause hemoperitoneum. So this is something you have to talk in a report. Subcapsular exophatic location, you have to talk about it. Okay, if it's a guy, it can undergo cancer, cancer change very quickly. So again, people will worry about this. Again, size more than 5 centimeter, higher risk of malignant transformation, and inflammatory or beta catenin I told. These are two which have a risk of malignancy. So this is where they worry, right? So size more than 5 centimeter, we can tell them. Male, they already obviously gender is known, and we can sometimes tell them the subtype. Okay, so that is where imaging becomes useful. Okay, if there are multiple, they're not very fat containing. We're not sure what they are, but they're all like 3-4 centimeter. And they will follow it up, right? So then they will just follow it up. So follow-up becomes important. You have to continuously compare the sizes. If things are increasing, especially 1 or 2 lesions are increasing, you have to point those out. And when anything becomes more than 5 centimeter, then they will intervene. Okay. So that's about adenomas.